G'day, my name's Andrew. We're going to be doing a reflection of my shoulder dystocia video. We're going to get straight into it. I'm just going to stop the video and explain a few things and skip past anything that's not pertinent.
Hello, Andrew. I'm doing my assessment.
So,
Talking the peritoneum.
I noticed that the mother is presenting. I noticed a fresh shower of blood. I see the dilation of the baby presenting its head and the bulging of the perineum. I put that pressure on and then I allow the baby to be pushed through. I'd be switching the mum through contractions to push and to breathe consistently and relaxed out of their contractions. Something I don't do in this that's really hard to do with a doll. However, something quite important in the real world as a real patient that does need that coaching and that assistance and that confidence. One other thing I don't do here, and it's quite something that you don't notice when you're doing it with a dummy, is getting that like approval, a consent, and that comes a lot more from informed consent. Letting them know why I'm doing things. I'm putting perineum pressure on to stop the potential for trauma as the baby is coming out. Now, this allows the mum to know why I'm doing something, and if it makes her feel more comfortable about how things are going. As I go forward, I don't necessarily explain things as well, and I'll go into say exactly how I would explain it to the mum.
All right. So to start, I'm going to lift mum's legs.
Yeah. So I say we'll lift mum's legs into a deep squat.
Deep squat.
And then
contractions.
I say that's not working.
So it's not quite working. So I'm going to push
So
his head, both shoulders.
Push the shoulders and I say what I'm doing. Don't say why. Now this is really important. I put mum into the McRoberts maneuver. I need to say McRoberts, not just for the exam, but for my offsider. They know why I'm doing McRoberts. It's because the baby's having a hard time. They know what I'm doing and why I'm doing it. I can also explain, Mum, we're putting you into a position called McRoberts. It's a deep squat. This is going to help open up your pelvic cavity and help give the baby more space to move through. I'm going to be putting pressure just above your pubis and pushing the baby's shoulder anteriorly. And this is going to help the baby roll and potentially clear the pelvis. All right. And that explains what I'm doing. I'm doing a Rubens, I'm doing a McRoberts. My offsider knows why I'm doing it, and the patient knows why I'm doing it. So these are small things that confirm with my mentor or my offsider, and also confirm with the mother themselves. That needs quite a bit of that coaching.
Okay, as it comes through.
Another thing I didn't do is say everything is fine. I shouldn't have said that's not working. And that's a small thing. It wasn't working. But I shouldn't be saying it. It will stress the mother out.
Just baby.
So baby comes out. I stimulate the baby. Complete my APGAR. So the baby was at APGAR of 9, which was fine. I already assumed that the baby was going to be APGAR of 9 just for the scenario, so I had to go through my full APGAR and change something of what will be a more likely presentation. As I've gone through, I've kind of put the baby down, and now I'm starting to go through the baby's respiratory status, just checking to make sure the baby's breathing properly. What I haven't done is checking the mother. I have 2 patients there. That's something that it's easy to forget when the baby is in my hands or when I'm constantly checking the baby. But the mother is another patient. And as the baby is completely fine with APGAR of 9, progressing to an APGAR of 10, the mother, I have no idea about her status. This is where I can check the mum's perfusion, check her GCS, seeing if she is desaturating, if she is declining in condition, seeing if there's a fresh show of blood, checking that uterine tenderness and that rigidity. If it's quite soft and quite tender, I might need to help by putting some pressure, doing a bit of a fundal massage to help that uterus get rigid. If she is bleeding, then that's when I need to start considering oxytocin. As a treatment for the postpartum hemorrhage, not just for delivery of the placenta. So these are small things that actually are quite important when it comes to my patient, because I've got one patient I'm not paying attention to. So I go through, I do my respiratory status, the baby's breathing
So-
fields.
Now I'm just going to watch the umbilical cord.
So I check to see if the umbilical cord is pulsating,
I'm going to cramping umbilical cord.
and exactly what I say there is wrong. What I should be saying is, Mum, have you got any plans for the umbilical cord or the placenta? And is there anything that you need me to help you with? And if she says, no, I haven't got any plans, would you like me to clamp and cut the cord once the cord stops pulsating? And if she says yes, then I can move forward. If she says no, I'd rather leave the cord attached, non-clamped, and hold the placenta with the baby. That's her right, and it's on my job to respect her wishes. Now, I haven't necessarily done anything she hasn't wanted, but the way I phrased it made it seem like there was a plan that I have, and it's not her plan. As something that we've been taught with delivery is that it is the mum's plan, and we are just there to assist unless something goes wrong. So making sure I have that open communication and not kind of closing off her options. So she says that she wants me to cut the cord. So I go through and I clamp 5, 10, 15. I cut between 10 and 15, which was fine. So I allow that cord to go off to the side. I go through and I ask to wrap the baby. I wrap the baby, I swaddle quite loosely, which needs quite a bit of work from experience, just swaddling tight up, giving them a really nice swaddle to kind of simulate being in the womb. The baby get quite a bit of reassurance from that. I go through my APGAR, which gives it a 10. So I swaddle and I place the baby on mum's chest. I should be coaching on latching for that oxytocin delivery. And now we're going into the third stage of labour, which is the delivery of the placenta. I ask, we have two options. We can give you oxytocin for a help of the delivery, or we can allow physiological, so no oxytocin, delivery of the placenta. The mother opts for no oxytocin. This is something where I would talk to the patient before delivery, if I had the chance. Not in this scenario, as we start with the deliveries, the second stage of labour. However, this would hopefully be understood prior to delivery. One other thing I can do is get the mum allow the mum to be comfortable, so she may want to lower her legs and be covered up, just for decency. So going further forward, she wants to deliver the herself. We'll speed up time and the mum can feel the contractions. I would see a fresh cell of blood, something I don't state here, the feeling of wanting to deliver and that lowering of that fundus.
Until we see that placenta.
So as it comes out, I help roll it. This is where I can explain the mum might be a bit confused about, might feel a bit weird. And I'm just rolling the placenta to help it stay intact so that no placenta is retained inside the uterus. All right, and then I can check the placenta. One thing I do here, and you'll notice it straight away, is that I'm looking at the placenta, but not the mother. The placenta can sit to the side. The placenta is not going to die. It's not another human. The mother can. And I'm not paying attention to the mother. I'm not checking the mother, seeing if there's any more blood. Postpartum hemorrhage right after placenta. I'm not seeing if she's desaturating, if her perfusion's going down, if she's had a loss of consciousness. Quite a bit of blood can be retained in the uterus before it's actually seen externally, especially if they're laying on their back. So checking on the mother continuously throughout this process is of absolute importance, something that I have critically missed during this scenario. So going further forward, I'll have to make sure to consistently check the mother and make sure she's fine. I check the placenta is intact. I see that it's fresh and red and it's stopped pulsating. So I place the beanie on the baby. Something I could have done at the very end, at the very beginning, when I had wrapped the babies, put a beanie on the baby. However, that's a small thing that I'd have access to at the time and have laid out. Another thing is having some of those tools for something wrong going on, like a neonate resuscitation, having a oxygen kit, a neonate bag valve mask, potentially the drug kit with the adrenaline and a BCG ready to go for the mother as well. Having that all ready because it's quite time critical. So having that off to the side, and just being ready for the potential for things to go wrong is definitely a point that I'll be implementing further in my practice. So the big key takeaways for this is making sure mum is comfortable and knows everything that's going on, explaining why I'm doing things. Checking mum as a second patient is my biggest takeaway. She is another patient. It's a unique thing of this scenario that we'll have two patients from one call out. She's once the baby's been established that the baby is fine, an FGAR of 9 or 10. I need to be making sure mum's okay, that she hasn't got any bleeding or major trauma. And then preparing my scene, being ready for the worst to happen of neonate resus and potentially a resuscitation of the mother from blood loss. So those are quite critical, important things. With the most easily implemented being explanation why I'm doing things to the mother. That helps them know what's happening, my offside of knowing what I'm doing, and it just establishes that I know what I'm doing. So that's my key takeaways from this reflection, and I'll be implementing further in my practice. Thank you very much for watching, and have a good day.